Good morning, everyone. I want to welcome you again to this 2007 series of the Biomedical Research Caucus. As you know, we've had dozens of hearings on cancer, Alzheimer's, malaria, and so anytime any one of your offices wants some particular topic brought up, we'll be delighted to bring it up if you bring it to our attention. This year, you know, we have our co-chairs who have worked so hard to double the NIH over the past several years. Brian Bilbray, Mike Castle, Lois Capps, and Rush Holt. And this year, in particular, I don't have to tell you, a very highly constrained fiscal year. At this very moment, the budget resolution is coming out, and before the appropriations committees, the 302B allocation is being made, and we'd like your officers to pay attention. There are letters floating around both in the House and the Senate that ask funding for the NIH, and I know you're interested, and I hope your members will sign on. It's really a desperate year, and we truly need your help. Today we'll learn about the increasing prevalence of diabetes and obesity. The Centers for Disease Control has projected that 1 out of 3 children born in the United States in the year 2000 will develop diabetes in his or her lifetime. Most of the increase in diabetes is related to an increase in obesity. 58 million people in the United States are now considered obese. My God, it's 1 out of 6. So these are complex diseases, and they're tied to genetic and environmental factors. Basic and translational research has begun to shed light on the ways by which metabolic pathways are influenced by genes and environment. We're on the verge of major breakthroughs in recognizing the gene-environment interactions that underlie obesity and diabetes. So I would like to call at this time on a distinguished scientist that comes from MIT. He got his PhD in Stanford, and he got his MD also at Stanford. And he is an authority known throughout the world on writing and researching on diabetes. So we're privileged to have with us today Dr. Mitchell Lazar. He is now the director of the Institute for Diabetes, Obesity, and Metabolism at the University of Pennsylvania. Dr. Lazar.
Well, thank you, Peter, and I would like to reiterate my thanks for the invitation to come speak to you today about this topic, which is very important. It's always a little tricky talking about this topic while people are eating, but I'll do my best. Usually people leave stuff on their plate by the time I'm finished. What I'd like to do today, of course, I'll have to paint broad strokes, but I'll try to give a few specifics about the enormity of the problem of obesity, and in particular, type 2 diabetes, which is one of the major morbidities of obesity and leads to some of the greatest deleterious health consequences. I'd like to share the progress, much of which is funded by the National Institutes of Health and led, historically at least, by the United States, although this is a worldwide problem. And then I'd like to end by talking about the potential to not only fight and sort of try to keep up, if you will, with the epidemics, but even to turn them back and to win. Many of you may have seen slides like these. These are taken from the CDC website. They're publicly available. They represent obesity trends in the United States. And I am starting in 1989. In Washington, there's a danger that you'll think I'm showing a political map because the states will be shown in blue and red, but actually I'm showing you weight distribution of people in the United States. And I'm going to scroll through these rather quickly, but I want you to notice we're looking at, as we've heard, a prevalence of 10 to 14%. I hope you can, I don't know how well you can see this, but the colors, as it gets bluer and then redder, that's a problem. And this is 1992. Last white state gave in. We start getting into the yellows, which is greater than 20% obesity in 1999. Gets redder and redder because obesity, as you know, is increasingly prevalent. As in 2005, in this case defined as a body mass index greater than 30 or 30 pounds overweight, greater than 30% of the United States population in many states. Diabetes looks basically the same. You'll notice that the number here is lower because not everyone who's obese gets diabetes. That's sort of an interesting reversal to the problem that I'll be talking about, why people who are obese get diabetes. But you might ask, why doesn't everyone who's obese get diabetes? And that's probably the other side of the coin. I'd be delighted to discuss that if there are specific questions about it. But here's going from 1994 to 2004. And again, in this particular case, the redder the country is, the greater the number and prevalence of people with diabetes. And it's really dramatic. So again, this is CDC, available to CDC. I encourage those of you who give presentations related to this to do as I did there in the public domain, and I think it really, I hope, makes an important point. Now, when we think about these epidemics of obesity and diabetes, I think it's pretty obvious, as you're eating very nice food, that we should be eating less. It's also obvious, probably everybody here knows this, that we should exercise more, and if we already are exercising more, we certainly know that the other guy over there should be exercising more. These are things we know, but we shouldn't stop emphasizing how important they are. Nevertheless, the environment that we're in, including the easy access to high-caloric foods, as well as the availability of remote control and cars and the lesser availability of easy ways to walk or bike, contribute to this problem. And importantly, genes contribute to the problem. In fact, it's probably, and I'll emphasize, genes that are the answer to the question of why everyone in our same environment doesn't get obese, and why everyone who's obese in our same environment of copious calorie availability doesn't get diabetes. But again, although obesity is in the background, and it's clearly the critical causal factor of type 2 diabetes, what I wanted to focus today on was diabetes, because it is the biggest health challenge to our increasingly obese population. And here, I wanted to make sure that we're on the same level playing field, so to speak, and so I'm going to spend a couple of minutes defining diabetes. I apologize for those of you who know this already, but I find that it's very important that we all understand what we're talking about at the same level. Well, diabetes refers to abnormally high levels of sugar in the bloodstream. And there's a couple of different ways it can be diagnosed. It can be the blood test you have fasting, and that's why when you go to your primary care physician, they'll typically ask you to fast before measuring your blood sugar. But there are also ways to measure the blood sugar after eating, particularly in the situation of pregnancy, where the pregnancy-associated diabetes is typically diagnosed upon a challenge with a sugary drink. And then there are two types of diabetes. There are type 1 and type 2. As I'll emphasize, I'm going to talk about both briefly, but then I'm going to focus mainly on type 2, because type 2 diabetes is the one that's primarily associated with obesity, and it's primarily the one that accounts for the vast majority of the number of cases in the epidemic. It's important to understand that they're both called diabetes because the blood sugar is high, and the complications, which I'll mention in a moment, are essentially the same. But the causes are different. Again, that's important for us as we approach both of these diseases. Now, what are the shared complications? There are acute complications. If you have a high blood sugar due to lack of insulin, that can affect how you think, get dehydrated. And also, if you have low blood sugar, often because a diabetic patient takes too much insulin, that leads to hypoglycemia or low blood sugar, and that is a medical emergency. But the real insidious aspect of diabetes are the chronic complications. These affect all major organs. They include blindness, stroke, heart disease, kidney disease, atherosclerosis, meaning hardening of the arteries that leads both to heart attacks as well as to stroke, as well as to inadequate vascular supply to the legs that leads to foot ulcers and amputations. These take time to develop. So the patient who has a high blood sugar and then corrects it with insulin is not at risk for these things on the immediate basis, but it varies with the individual. But typically 10 years of diabetes is when we start to see some of the complications that I'll talk about more in a moment. And tight control, and I'll show you the evidence for this because it's so important, can delay or prevent these complications. That used to be a theory. Now it's a fact, and I'll explain why. First, let me spend 1 minute talking about type 1 diabetes. It deserves more than 1 minute. It's a terrible problem that affects many thousands of particularly children in our country, and I don't want to give it short shrift, although the focus today will be type 2 diabetes. Type 1 diabetes, as I mentioned, commonly occurs in childhood. It's formally called juvenile onset diabetes. When people think of diabetes, they're frequently thinking, I find, of type 1 diabetes. This is caused by the immune system mistakenly destroying the cells in the pancreas that make insulin, and that leads to complete lack of insulin. Because there's a complete lack of insulin, these patients have an absolute requirement for insulin 24/7, or they won't live. Their lifespan can be measured in weeks or months. The development and discovery of insulin by Banting and Best in the 1920s was unbelievable breakthrough, and the availability of insulin has saved the lives of patients with type 1 diabetes from the acute complications, but it's not a cure of the disease, and they still can get the complications that I mentioned earlier, typically, as I said, 10 years after the diagnosis. And this disease, as devastating as it is, accounts for a minority of all the cases of diabetes in the United States. Typically, the number quoted is about 5%. The other 90 to 95% are type 2 diabetes. Type 2 diabetes is the one that's associated with obesity, but not always. It's also what patients who are pregnant women who you hear about gestational diabetes, that's type 2 diabetes. The aging-associated diabetes is type 2 diabetes by and large. This was formerly called adult-onset diabetes, although somewhat scarily, it's increasing at a rapid rate in children to the point where in some communities, including potentially Philadelphia, where I'm from, inner-city hospitals it's suggested, will actually have more cases of type 2 diabetes in patients below the age of 18 than type 1 diabetes. Now, this is not caused by an absolute lack of insulin. This is caused by the body no longer responding appropriately to insulin. This is referred to as insulin resistance, and I'll try to give you some examples and even some metaphors to get this concept through. The patients have insulin, and early in the disease, patients with type 2 diabetes can actually have more insulin than patients without diabetes. In fact, because of the resistance to insulin, their own pancreas tries very hard to produce more insulin, and eventually it poops out. And when the pancreas poops out, for a variety of reasons, which we could talk about in the question and answer period if people have questions, that leads to kind of a dissociation, a disconnect between the need for insulin and the relative amount produced. The blood sugar can't keep up, the patient gets a high sugar, and is diagnosed as diabetes. As I mentioned, this accounts for 90 to 95% of diabetes in the US. Now, I want to illustrate what type 2 diabetes means to a scientist in the following way. In a normal patient, the pancreas is working. It's not like a type 1 diabetic where it's pooped out, and there's lots of insulin to take care of glucose. What insulin does is it drives glucose into cells through these things called glucose channels. And insulin, if you look at the second picture here, by binding to its receptor, allows glucose to flood into the cell. So after a meal, probably many of you right now have relatively high insulin levels, driving the blood sugar from what you're eating into your skeletal muscle, where it can be used for energy. It's also potentially driving it into your adipose tissue or your fat stores, where it's become something else. But in type 2 diabetes, particularly in the muscle and also in the liver, the insulin receptor is not functioning normally. The cell is resistant to insulin. When that happens, glucose can't get into the cells. It stays in the bloodstream. When the glucose stays high in the bloodstream, as I've emphasized, that's what diabetes is. So in type 1 diabetes, the glucose doesn't get into cells because there's no insulin around. In type 2 diabetes, the one that is the major form in our current epidemic, there's insulin around, but it's not working. It's kind of like if you're trying to communicate, because endocrinology and insulin hormones are about cells communicating with each other, if your cell phone's not working because the cell phone itself is dead, I guess that's like type 1 diabetes. Type 2 is when the signal is not getting through. And when the signal is not getting through in your cell phone, you could shout louder into your cell phone. And if you do shout louder into your cell phone, that's sort of like giving more insulin. The signal, the connection's not there, but you're trying to give more insulin. In fact, the solution to the problem would be to make the insulin work better, to fix the problem with the wires or with the phone. More statistics, and you've heard some already. 7% of the US population currently has diabetes at present. Minorities are disproportionately affected, again, primarily by type 2 diabetes. More than 3 million deaths worldwide attributed to diabetes in 2000. It's the 6th leading cause of death in the United States, which is bad enough, but it's very important to recognize that typically if someone dies of a heart attack, what's put on the cause of the death certificate is heart attack. But if the heart attack was due to diabetes, really diabetes is contributing to the death. And in fact, 2/3 of people with diabetes die of heart disease, which is the leading cause of death. And 50 million Americans on top of this 20 or 21 million Americans actually have this insulin resistance. Their insulin's not working properly. And even though they don't have diabetes per se, the fact that insulin's not working properly is putting them at risk with the syndrome that's called metabolic syndrome. So this epidemic kind of snuck up on us. You can't read this, so the patient is saying to the doctor, "Be honest with me, doc, how much longer do I have to ignore your diagnosis?" And I think that the obesity epidemic and the diabetes epidemics did sneak up on America, but I'm pleased to see that the media are realizing this now. There was a wonderful and really sobering four-part series and then occasional follow-up in the New York Times. The date of this is January 9th, 2006, talking about the emergence, the quiet emergence, as they point out, of diabetes as one of, if not the main, health threat to citizens of New York City. As I mentioned, type 2 diabetes is increasing in children. Diabetes earlier age means earlier onset of those complications. Remember I said it's about 10 years until you start seeing the problem. And gestational diabetes is increasing. And if a woman has gestational diabetes, not only is she at increased risk of developing diabetes later in her life, but it's coming out that her offspring have an increased risk of diabetes. So with more diabetics having kids, you can see this is going to just spiral unless we do something about it. The economics, I won't dwell on this, but in the year 2000, which is the year I found the best statistics for, there was a $132 billion cost of diabetes, $92 billion estimated in direct medical costs, 40 in indirect costs due to loss of productivity and so forth. 11% of our national health expenditures are on diabetes care, and 32% of Medicare expenditures are diabetes care. So for many of you thinking about the rising healthcare costs and looking at these numbers, I think the investment in the NIH to try to stem the tide of this epidemic is well worth it. The future looks even worse. 1 in 3 Americans born in the year 2000 will develop diabetes in their lifetime. 1 in 2 Hispanic females, 40% of African Americans. This is statistics taken from particularly from the CDC. This is the rate. It's another way of looking at that map of diabetes. These are the diagnosed cases of diabetes, and the x-axis is the year. This is the prediction, and then since this was predicted in the year 2000, look at the red dots. Do they fall on the line? They're actually, I hope you can see it, they're above the line. So as bad as this prediction looks, the reality is even worse. We can hardly predict how bad it's going to be. Worldwide, it's a similar problem. This is taken from New England Journal of Medicine, looking at the millions of cases of diabetes in the United States and across the world. The pink bars are in the year 2000, and the blue bars are what are predicted to be the case in the year 2030. And you can see it's not limited to the United States, not limited to even the nations we used to think of as industrialized. Obviously, more are becoming industrialized, and that's a big part of the problem. Okay, that's the really scary news. I hope you have the same fear of this than I do. I'd like to share with you some of the medical progress, including clear evidence that lowering blood sugar prevents the complications of diabetes. This is a landmark trial that was funded by the National Institute of Diabetes, Digestive, and Kidney Diseases. It's called the DCCT, or the Diabetes Control and Complication Trial, that's scientifically and rigorously tested, whether keeping blood sugar levels as close to normal as possible would slow the onset and the progression of diabetic complications. This is a huge question because of the other side of the coin of tight control, as it's called, of blood sugar. It takes tremendous effort from the patient. Many of you perhaps with diabetes or with friends with diabetes know how much effort they have to go through to check their blood sugar and so forth. It requires a team of professionals, not just physicians, diabetologists, but nurse practitioners, diabetes nurse educators, and nutritionists, and this is expensive and time-consuming. And it carries an increased risk of low blood sugar, which is a problem in and of itself. And therefore, for many years, there was debate about how important tight control was, but thanks to this landmark controlled trial from the NIH, it's very clear. Tight control of blood sugar works. There's a reduction in eye disease of 76%, a reduction in kidney disease of 50%, in nerve disease of 60%, and cardiovascular disease reduced, this is a typo, I'm sorry, but it's still about 40%, heart attack and stroke. Just a couple of examples. This is taken from the DCCT data. This is eye disease. These are patients with diabetes. This is not blindness, but it's evidence of eye disease. You can see that 9 years after into the study, patients on conventional therapy, almost 100% had eye disease. Patients who were under intensive therapy trying to keep and manage to keep their blood sugar lower than the conventional had, again, a really dramatic reduction in eye disease. This is heart attack and stroke, the killers of patients with diabetes and the major killers of Americans. These are the conventional treatment. This is the intensive care. In other words, almost about a 50% reduction. We have to, even today, recommend tightest possible control of blood sugar in our patients. Now, what about the future? I want to tell you a bit about some vignettes about the progress in basic biomedical science and how it's helped us understand how obesity causes type 2 diabetes, which we need to understand in order to understand how to intervene. Again, I want to emphasize that the public, and I like to see where Newsweek's priorities are when you look at what got the top billing versus the margin. This was the recognition, national news magazine, that adipose tissue, fat that we know is what the definition of obesity is, having too much fat, is actually contributing in an active way, sending out bad molecules, as Newsweek would say, attacking the rest of your body and causing the diabetes. There's been some major breakthroughs. This is in mice. If you look at this photograph, the obese mouse is missing a single hormone from a single gene, and that hormone is made by fat cells. It's called leptin. And if you treat these mice with leptin, that's the sibling over here, it got thinner. When leptin was discovered by Jeffrey Friedman of Rockefeller University in 1994, the hope was that most humans with obesity would actually have a leptin deficiency like these mice. In fact, most humans are resistant to leptin who have obesity, just like most diabetics are resistant to insulin. So it's a more complicated problem. But I do want to show you this. This is one of the rare patients. This is from a Turkish family that, for genetic reasons, is lacking leptin. And this is a 7-year-old boy who is morbidly obese, and when kept away from food, becomes ravenously hungry, and when food is put in front of them, will eat everything. When you see someone like this, it is almost impossible that it's because their mother or father are just bad parents and they're giving them access to food. You hear about patients being taken away from their parents because of morbid obesity. Undoubtedly, there are some parents who are not as diligent as they should be on this issue. But when you have a genetic disease, this proves that it can trump the environment. And the magic is that in this case, when you treat them with recombinant leptin, result of a partnership between the pharmaceutical industry and, in this case, Rockefeller University, it's a miracle. It would be nice if the garden variety obesity could be treated in this way. But again, it shows you the promise, and also the fact that fat cells, shown here in cartoon form, that make leptin, really are endocrine glands. I'm an endocrinologist, and they are glands just like any other. And they make all of these molecules. This is actually a subset. Don't worry about the specific names. But they poison insulin action in the liver and the muscle. A couple of them are actually good. I call them the good guys. That's leptin and another protein called adipinectin. But the most of them are bad guys. And they're what we call insulin resistance factors. They're part of the problem. How do we treat it? Well, one thing we do is we study fat tissue. And this is the only piece of data I'll show. This was a eureka moment in my laboratory when a very talented MD PhD student funded by the NIH's MD PhD program, who's now a professor at Stanford University, Jay Chavla, made the discovery that this factor has this name, PPAR, is specifically found in adipose tissue and not in all these other tissues here. That suggested to us it might be a link between fat cells and some of the things that fat cells do that are bad. And right about this time, discovery was made by the company called Glaxo that a drug that they'd already had on the market, and they didn't know how it worked, because that's how a lot of drugs on the market, they get to the market before we really know how they work. But they found in this beautiful paper that this drug was working through this receptor that we found in fat cells. And understanding this led to the development of new drugs that are now on the market for diabetes. Hundreds of thousands of people are treated with these drugs. And these drugs have the property of fixing the telephone wire. They improve insulin resistance. They also have major side effects, which limits their utility, although, as I mentioned, they're very widely prescribed. We can do better, but they're proof of the concept that research in this area will lead to improvement. I'll give you one other example. This is a Gila monster. Now, this monster has a venom that has a lot of bad things that it does, but scientists discovered that in addition to the bad things, one component of the venom of the Gila monster actually increases insulin secretion from patients who otherwise don't secrete it very well. That's because they make something which is analogous to a hormone that we have in our body called GLP-1. And several companies have taken advantage of this to create molecules that mimic, in fact, one is almost exactly the same thing that the Gila monster makes, and another blocks the degradation, the loss of the endogenous hormone. These are the names of these drugs. They're now on the market. And they're not the cure, the be-all and end-all, but their progress and their promise for our patients with diabetes. Just to give you a sense of that, in 1994, when the diabetes map looked like this, the patient came into my diabetes clinic. We told them they should be eating less, they should be exercising more, they should take the only oral medication. If that didn't work, or maybe while they tried that, they should take the only oral medication available. And if that didn't work, we had to put them on insulin. And even insulins have improved, but that was it. 2004, as the problem has become worse and worse, I'm pleased to say that at least we have more options for the patients, and we're staving off the complications of diabetes in large part by much better and much more intellectually based and rationally based therapies. I won't take you through this complicated slide, but I think you can tell it's a lot more options for our diabetic patients. And what's in yellow here are the new medications that made it to the slide, made in 2006, and even the ones that didn't make it to the slide because they're so new. They're options. We can individualize medicines based on, right now we do it based on the patient's profile. Maybe someday we'll do it based on more knowledge of their genes, their background, their family history, and so on. And now I'm just going to address briefly, although I'm not a biomedical engineer, another important advance that is in diabetic monitoring. Everybody, I think, has heard about insulin pumps. This is a cartoon, actually from a you can find this on the web, but it's put out to sort of, I don't know, make more human the issues of being on a pump for children. But a lot of people have this idea that diabetes pumps would look something like this. This says, have you thought about an insulin pump upgrade? And the insulin pumps today look like this. So a lot of people that you think are walking around with beepers are actually wearing insulin pumps. The other thing we can do is we can measure blood sugar non-invasively. Again, I'm imagining that perhaps some of you, but almost certainly personally, but some of you have friends or colleagues that are pricking their finger to measure their blood sugar. Now there's there's a lot of competition for what the right way to do this is, but continuous glucose monitoring not only is non-invasive, but also can, as shown in this slide, can show this is where the finger sticks would be, and patients had the finger sticks in blue, but they would miss these low sugar episodes, which are bad for the nervous system, and miss these high sugars, which would say that they're really not under such good diabetes control. The holy grail is using technology to link the sensor that tells you what your blood sugar is, so you don't have to check your monitor, and the pump that delivers the insulin. And that's what's shown here in cartoon form. This doesn't exist at all right now. But there are many companies working on this, and this would be a tremendous, and it's really, I'm guessing in the next 5 to 10 years, we'll have these so-called closed-loop systems, where without touching insulin, the patient's body, or rather the sensor would detect the glucose, send a signal that says the glucose is 200 to the pump that would then know how much insulin to deliver and be quickly checked to see if it was too much or too little. By the way, that's what our own pancreases do. So the closer we come to this, the closer we come to achieving the absolute tight control that non-diabetic individuals have. Okay, so I'm going to close up now by pointing out the challenges in the future. I hope I've not only scared you about the epidemic, but convinced you that we've made a lot of progress, but we haven't made enough, and I really don't think we've kept up with the epidemic, despite a lot of hard work by a lot of people. Where's diabetes research going? Well, in the case of this topic, which is obesity-associated insulin resistance and diabetes, despite what I've told you, we still need to better understand what it is about obesity that causes diabetes so we can figure out how to intervene with the fewest possible side effects for the greatest number of people. We know that there's a role of inflammation. This is brand new, that actually the body, in an obese person, the body is acting like it has the common cold. There's markers for inflammation that are increased, and we now know they're contributing to diabetes. What can we do about that? How about the brain and the nervous system? In a way that was never anticipated before, some recent scientific evidence strongly suggests that the brain is contributing with some of the organs like the liver, the muscle, and the pancreas in a two-way street via the nervous system. We need to understand that and figure out if that's, we know it's gone wrong in diabetes, and the question is, did it cause it or did it go wrong because of the diabetes? We have to find new ways to make the body more sensitive to insulin, fix that phone connection, and then we have to preserve or maybe make more of the insulin-producing cells in the pancreas called beta cells. And here's a very important goal that ties together type 1 and type 2 diabetes. We need to be able to get people's own body to make more insulin. This says, I guess it's a sign of the times. Instead of a Mr. Softy truck, this is a guy selling diabetes supplies out of a push cart. I hope we never come to that. But it's going to take some time. I wish I could tell you that there's a cure tomorrow or 6 months from now, and I hope I've convinced you that in a 10-year period that I've emphasized from 1994 or to 2004, and then of course to the present, we've made great strides. But we need to keep working at this. And this will also include training the next generation of physician scientists so that when I'm gone, there'll be people following the same path. And I can tell you it's getting to be a harder and harder sell, and I'd be happy to talk about why that is. We also need to train the next generation of people who are going to take care of patients with diabetes. That diabetes control and complication trial proved that tight control is critical. Tight control takes a team, takes a village, you could say. And it takes, we try to do this at our own diabetes center, and it's very expensive. The New York Times ran one of those 4 articles, was all about this. We need to recognize the need for intensive therapy. This is a team approach that I just emphasized. And we need to beware of this slide taken from one of my more pessimistic colleagues who is concerned about lack of funding, lack of mentors, and lack of mentors who are happy about their own funding, school debt, and clinical demands all conspiring to reduce the interest in the brightest minds, medical minds, and people who might otherwise go into medicine, reduce their interest in diabetes right at the time when we most need it. And so I'm going to stop here. This says, now I'll just press the delete diabetes key, and I just wish it were that easy. It's not that easy, but there is hope, and I really hope I got that message across. This is where I live. Those of you who take the Amtrak between DC and then go past Philadelphia, you can see us as you go by and head toward 30th Street Station or New York or Boston. But please stop in if you're in the neighborhood. We'd love to show you what we do and show you some of the people who do the research in my own group, in our own department, and who really care about this and live this on a day-to-day basis. I'd like to point out that even in my own work, and I can't list all the people, this is a very collaborative effort. I personally could not have done this without support at every level of my career from the NIH, and more specifically in the past 18 years for me from the National Institutes of Diabetes, Digestive, and Kidney Disease, one of the great institutes of the NIH, as well as private organizations like the American Diabetes Association. And finally, this is taken by one of my coworkers, Mo Katani, and I'm just going to show you this and end. This is a photograph taken outside of our building. These are two pigeons. I hope you can see it in the back, and I hope you can tell that one of these pigeons is a little svelter than the other. And Mo actually is a mind reader, and he could tell what these pigeons are thinking. This one was saying, the thin one is saying it's all willpower, and the heftier one is saying, I wish I had her genes. You know, I don't know what the genes are of these pigeons. It's hard enough to study people and mice. I'm pretty sure they're exposed to the exact same environment outside our building in Philadelphia. And I don't know what the willpower of pigeons is like. But I think what this points out is that there's a combination of factors, many of which we don't understand but need to understand at the environmental level, because certainly around our building there's lots of crumbs that these pigeons are feasting on. But there's also genetic factors that determine why one person of a given ethnic group is more predisposed to diabetes, or one person of a given country of origin is more predisposed to diabetes, why some people with obesity are more disposed. And it'll be the science, the underlying science, that will lead us to those answers that, in combination with the human genome, give me great optimism that we will one day, in the not too distant future, be able to personalize our therapies and really take advantage of this knowledge for every person to both prevent the onset of these diseases and to treat them. Thank you.
When diabetes changing? And the other question is does exercise have an independent effect on the incidence of type 2 diabetes that is independent of the fact that it's correlated with weight?
Yeah, those are two excellent questions. The first was whether the incidence and prevalence of type 1 diabetes is increasing. The answer is yes. It's possibly we don't really know the factors. Type 1 diabetes tends to be caused by some kind of insult, usually a viral infection on top of genetic predisposition and autoimmune problem, but it's also increasing. Could it be related to the same factors, diet and lack of exercise as type 2? We don't know. It would certainly be possible. Second question had to do with whether an exercise program can stave off diabetes independent of weight loss. Is that the question?
Well, does the exercise or lack thereof does it correlate to the incidence of type 2 diabetes if you factor out somebody's weight?
Yes. So it's a very complicated question, and I can't answer it definitively. I can say that exercise absolutely is a good thing when it comes to diabetes. Even in patients who have no insulin, type 1 diabetics, when they exercise, the actual act of contracting muscles puts into play a separate pathway that doesn't involve insulin, that pulls blood sugar out of the blood into the muscle. So even with zero, in fact, those of you who unfortunately may have children with type 1 diabetes or know of them know that they have to reduce their insulin requirements before they go and play soccer, for example, or exercise in another way. And that's really proof that it is very beneficial for blood sugar control.
Yes, wait for the microphone, please. Yes, sir.
I was wondering what proportion of the increase in diabetes is attributable to the increase in obesity, and what is known about other factors?
Yeah, great question. I've emphasized obesity, and I should say that I can almost take one step back from your question and say, why do we think obesity has anything to do with this? And it's really two lines of evidence. One is the incredible parallels, which is just a correlation between the rate of increase of obesity and the rate of increase of type 2 diabetics. But the second is that even in animal models ranging from subhuman primates like monkeys to mice and rats, if you make them obese, they will get diabetes. So even in those model systems, we can show a cause and effect relationship. But are there other factors? There almost certainly are. We can all, aging is a factor. The population is living longer, thankfully, thanks to modern medical care. And I thank you as well for as I age. And that increases the risk of type 2 diabetes. We don't fully understand why, and we don't know whether it's the same causes as we see maybe accelerated by obesity, which is one theory, versus a sort of parallel set of causes. That's one example of a very powerful factor.
Dr. Lazar, let me ask this question at this moment. Is there any particular nation throughout the world that has a higher rate of diabetes than others? Is there anything like that?
There are some nations of, it's a really excellent question, and people have learned from this. There's some islands in the Pacific, the Inuit Indian population in Canada, and even, if you will, the Pima nation, the Indian nation in the United States. These people are clearly at a much higher risk of diabetes than average. It clearly correlates with the advent into their societies of high-caloric foods, modern technology, and so forth. So the environmental factors are clear there, but again, there are genetic factors because of this increased risk. And actually, there's some studies looking specifically at some of these islands because there's more of a common genetics going on there to try to find out what some of these factors are.
I may be opening up Pandora's box, but according to some recent studies, it has shown that embryonic stem cells have helped or can help in type 1 diabetes. Does the same hope lend itself to type 2 diabetes?
I would say that, from my perspective, the ability to make insulin would be critical for type 1, as you say, and in type 2 diabetes would also be critical because, as I said, the beta cells are pooping out at the end, and if you could come up with cells from any source that the body could tolerate, and one very attractive notion is that we could make them from stem cells, it could help type 1 as well as type 2 diabetes. I would even go so far as to say that since you're talking about the production of a hormone that then goes through the bloodstream and works, it doesn't matter where in the body those cells were put, as opposed to some other areas that have been also suggested that stem cells may have promise, and they may very well, such as Alzheimer's disease, for example. But there, it's a much trickier issue where I'm not even exactly sure where you'd put the stem cells in the brain and so forth. Here, it's pretty clear that if cells of any type could be made to make insulin and not be rejected by the body, it would be incredible boon, not only for type 1, but also for type 2 diabetics.
Yes, sir. Yes.
Good afternoon, Dr. Lazar. I want to thank you very much for your presentation. And my question deals on policy. If I'm a member of Congress, what is your advice to me? How do I translate the research that you're doing into shaping good legislation? I know that my district, that diabetes is the number 2 leading cause of morbidity in my district. I'm concerned about it. As a legislator, I'm responsible for how we spend and authorize funding. And just to say, well, to increase the funding for NIH, I can't translate what NIH does to the lives of constituents in my district in a timely manner. So what data would be helpful for me to understand about the issue of diabetes that would help me to formulate legislation that I could give my colleagues to support who also may have the same issue occurring in their district?
Well, first, thank you for your kind words, and thank you for your concern about this problem, because it is really absolutely critical, as you say. I really have a kind of a complex answer to your question, because I think it's a complex question. I think that we need to encourage education and lifestyle changes at the ground roots level, and any legislation that can improve nutrition and that can improve, maybe perhaps create incentives for a better nutritional environment in our schools, in our community centers and so forth, would clearly be a plus. If we can change habits of people, that gets a lot harder to change behavior, especially in adults. That would be wonderful, and there are many ways people are talking about this, about doing this, and that should be encouraged. At the same time, I fear that it's very hard to change behavior. We have to keep going at it, but we also need to understand that people don't want to give up their remote controls. They don't want to give up their cars. Many people don't want to give up the way that they're eating. And at the same time, as we try to change their habits, educate, especially the youth, early, we need to realize that in the present day, we've got all these people, and every day there are more with type 2 diabetes. And for those people, we have to make available healthcare that's existing now, but also realize that it's not good enough. And I hope that I've shown you examples, and there are many more that I could give, of NIH-supported research that bore fruit. I wish it happened the day after the grant was funded. I wish it happened the year after. But it takes time. It takes 5 to 10 years. I tried to emphasize a 10-year period in which we've dramatically changed how we treat patients with diabetes, which is clearly contributing to the improvement in mortality from, for example, cardiovascular disease. It was just in the news that the rate of heart attack, people dying from heart attack in the United States, is decreasing. This is spectacular, great news. While an awful lot of these people have diabetes, and an awful lot of that benefit is from taking better care of their diabetes through these medications that I've mentioned, and others, of course, and our whole approach to diabetes care. We have to keep doing that because the problem's not solved. So I would say that if we could keep going for another 10 years at the same pace, we'll be barely keeping up with the problem. I think we have to go at a faster pace at the research level myself. I hope that answers your question.
Elaine?
Hi, I have a question about your genes. Do you think there's a connection between your set of genes and whether you should be eating a low-carb diet or a low-fat diet?
Luckily, I'm wearing a suit, so I don't have to tell you about my genes. No, that's a fantastic question. And it's often that I'm asked for dietary advice, and I'm often trying to give myself dietary advice. One thing I know that is true is that based on my genes, I should be eating less, and probably most of us should be eating less. We know that in flies and worms, but also in mice and people, eating less, so-called caloric restriction, is associated with living longer. And part of that is by improving the pathways I'm talking about, less obesity, less diabetes. So definitely, we should all try to eat less, and you asked me a personal question. Yes, I should be eating less. What should I be eating? That's the next question. It's a critical question. I think it's pretty clear that I shouldn't be eating junk food, largely because it's this concentrated source of calories. If you actually look at some of the fast food that our kids are eating, that maybe some of us eat when we're in a hurry, in one burger, there could be a whole meal's worth of calories, and yet we eat 3 burgers. So too many calories is bad, and fast food is a way to deliver those calories. Now, should those calories that we do eat be in the form of low carbohydrate, such as has been suggested by many dieters, sort of was a fad for a while, and many people are still doing it, or should it be low fat? And if we go into the store, we see, quote, light foods, that tends to mean low fat. I personally don't think we know the answer to that. There's evidence that both work for a while, and there's evidence that after a while neither works because people go off their diet and can't keep to them. People crave certain foods, and so if you only restrict them to one, I'm not sure that really works either. I do believe that as we understand more about, you asked about my genes, once I can look at a map of my own genes and see where I could use some improvement, and since I can't improve them directly, my belief is that by understanding what those genes do, we'll be able to say in a personalized way for people, for this person, or maybe for this group of people, they're better off on a low-fat diet. for this person or maybe this group of people, they're better off on a low carb diet. That'll be personalized medicine, personalized nutrition. Some people call that nutriogenomics. It's the future, but now that we know we have the human genome sequenced, and it's possible to imagine getting the sequence of DNA of each person in this room, doing it on a population basis and looking for these correlations. I don't think it's science fiction. I think in the next 5 to 10 years, with the right amount of effort, we'll be able to make some interventions that are very personal, even in terms of diet. But right now, I recommend moderation.
Well, Dr. Lazar, if you do get a genomic profile, let's assume that for discussion in the next 5 years, what do you do then?
So I think that just in the past couple of weeks, the emergence of what's called high throughput genotyping has led to the simultaneous discovery by several groups, but importantly, one in Iceland, one in Boston, of several genes that were not previously identified as being associated with diabetes. The power was in being able to look at the exact DNA sequences and to look at a large number of people. And we would like it if we found 1 or 2 genes that conferred a risk that was huge. But in fact, what's going to happen is there are going to be 30 or 50 genes that are only mildly defective, but in combination create the risk that we then see on a population basis. And it's going to be kind of a mix or match kind of thing. If there's 30 of them, I might have 10 that are predisposing me toward diabetes, and then understanding what they do in the body, if they're involved, for example, just hypothetically, in fat metabolism, then knowing that, we might really focus on my fat intake, dietary fat intake. If they're involved in carbohydrate or glucose metabolism, we might look at the sugar in the diet. And then we'll be able to test this over a large population of people. And I think many, I certainly am frustrated, and perhaps some of you are, by the very large studies that get a lot of funding and a lot of publicity that we then read about in the paper that say, okay, vitamin E is not actually good for you. And I believe that the problem with those studies is that we're saying everybody's the same. And we're just saying everybody's the same, we'll just put some on vitamin E and some not, and we expect. But if it's a small effect, we may only see it in certain populations, and those populations will be identifiable by these pieces of their genes. And once we can do that, then as a physician, I can say, you're the one that should be on vitamin E, you're the one that should be on low-fat diet. And that's, I really think, is a very plausible scenario, and an optimistic one.
We just had a question about what the Congress could do specifically in their own districts about diabetes. Let me ask you this question. The last few years, the NIH has been substantially flat funded. It's always been a bipartisan effort, but that's what happened. What effect does that have on your research? Did you notice anything in your studies, and new people coming on having grants? What did you notice, if anything?
The biggest problem is the effect of the flattening of the budget on the morale of scientists who are dependent upon the NIH for doing their research. And as many of you know, the way the university and medical school, the whole academic infrastructure has evolved, I would say, in the United States, is that the NIH is not just that place in Bethesda. The NIH is me. The NIH is the University of Pennsylvania, and so many people at my institute that are funded and that funding not only helps them do their research, but teach the next generation of students, attract the next generation of students, get undergraduates interested instead of, very important, but some of the non-medical fields. And increasingly, I'm seeing people one important statistic is that the average age of obtaining the first independent grant for a new investigator from the NIH is risen to about 42 years of age. 42 years of age. By the time someone is 42, they have often a family. They have personal career decisions that they need to make, and if they're looking at their future when they're 32 or 22, and they're told, well, when you're 42, that's when you're getting your first grant, your first job, and guess what? 5 years from then, you only have a 20% chance of keeping that funding going. So at 47, you'll be looking for a new job. And your alternative is being a practicing physician, or maybe going to Wall Street, or maybe going to law school. We're losing the best and the brightest. And I think this not only has important consequences for the prospects of improving these diseases, but also for the prospects, has economic consequences. I think that by losing these young people, we're eventually going to lose our edge, and this is one of the few areas that I believe we have an edge on as an industry. The biotech industry is one of our jewels, and for the first time, I'm seeing people that I train who are Chinese, for example, going back to China, getting better job offers in China than we can give them here, and more stable funding. And I'm very worried about that on several levels.
Thank you all very much. Thank you very much, Dr. Lazar, for a very splendid lecture. We want to thank the Joint Steering Committee for Public Policy for sponsoring this luncheon. I want to tell you that just a couple of weeks from now, on May the 23rd, we're going to have an excellent topic on synthetic biology and the war on malaria. Thank you very much.